But I think, yes, we're having good number, mashallah. Assalamu alaikum wa rahmatullahi wa barakatuh. It is a real pleasure being with you tonight in something a little bit new for me, but nevertheless is the basic of all cardiac diseases. And talking today about preventing atherosclerotic cardiovascular disease, focusing on dyslipidemia, joined by two experts in the field who are well known with their contribution in the field of cardiology and cardiovascular disease. And I'm pretty sure it will be a very fruitful and successful meeting. Looking forward to their talks, followed at the end, inshallah, with questions. And well, very sure you will have very full, complete answers, as much as possible, as much as our knowledge is. So without further ado, it's a real pleasure to introduce a dear colleague and a teacher of the generations, Professor Mustafa Shmeri, who's a professor of cardiac sciences and the chairman of cardiac sciences at the Department and College of Medicine, King Saud University, also a consultant cardiologist at King Saud University Medical City. He will speak to us today about the effect of LDL cholesterol and impact of early intervention in atherosclerotic cardiovascular disease. So please, Professor Mustafa.
Thank you very much, Dr. Walid Al-Habib, Saudi Heart Association President. It is my pleasure to be with you and Dr. Fakhr. I hope that it will be an enjoyable night. كل عام وأنتم بخير جميعا. The title, in fact, is the effect of LDL and the impact of early intervention. We talked a lot about the dyslipidemia, but tonight I am going to concentrate on the long-term exposure and the advantage of early intervention. And then we will go through a different part of the dyslipidemia in terms of how it developed, and then how long exposure will cause a problem, and then what is the percentage of achievement, what is the residual risk factors, and the solution and the role of the new generation of the drug to reduce the LDL. So first of all, I want to present this case to you. She is a 12 years or 10 years old lady who had, you can see that the xanthelasma all over her body, and she developed myocardial infarction at the age of 12. So she had at the age of 12 years to develop myocardial infarction. The reason is that what you see here in the tendon as well as at rest is related to the position of the cholesterol. I want to say cholesterol, that's why the color is yellow. The LDL cholesterol is the carrier of the cholesterol itself. So what you see here in the tendon of this young lady, unfortunate young lady, is similarly occur in the coronary arteries as well as in the cerebrovascular arteries. So what we see is atheroma formation in all over vasculatures, similar to what you see in this case who had an MI at the age of 12 years. So what we have, the atherosclerosis is just a process of development of atheroma, as I've shown you in the xanthelasma. It will be in the cerebrovascular area, which can cause stroke. It is in the peripheral artery, which can cause an ischemia and amputation. It is in the coronary, and it can cause a stable coronary artery disease or unstable coronary artery disease in terms of unstable angina, non-STEMI, or STEMI. So all of this is atherosclerotic process triggered by development of the cholesterol ester in the intima of the vasculatures, and subsequently the whole reason behind that, in fact, is the LDL. LDL is a lipoprotein which carry the cholesterol. So internationally, that number one cause or number one risk factors to cause the first myocardial infarction according to the Interheart is the lipid. You can see this yellow part is the most common risk factors for the development of first myocardial infarction. You can see we have 9 risk factors, but the most important of them, in fact, is the lipid disorders, which present for the first time any they did the study on the patient who had the first myocardial infarction, and they found that this is the risk factors, 9 risk factors, which can precipitate myocardial infarction, but the number 1 factor was lipid disorder. The prevalence is quite significant in the outpatient setting of primary health care. In Saudi Arabia, it was 70%, almost 70%. They have the dyslipidemia. So 70% of the patients visiting your clinic, they have dyslipidemia, and of course, additional risk factors is there. But 70%, remember, is a huge number in our patient who's visiting the clinic. So the atherosclerotic process, in fact, is like what you see. You start with having no problem in the blood vessels, then the cholesterol will start deposited and slowly progress until the atheroma formed. Once the atheroma is formed, then it will rupture by tearing and wearing process. And then this tearing and shearing process will lead to the atheroma rupture, and it will cause cardiovascular events. Or it might not rupture, but the progress until it substantially reduce the lumen of the coronary artery, and it will cause chronic coronary syndrome. So that's the whole thing. And so many risk factors, but the main risk factors to start with the process, in fact, is the cholesterol deposition. You can appreciate here that they found that the lower, by all study, that the lower the LDL, in fact, the lower the cardiovascular events. So that's why now, considering the LDL, not only reduction of LDL will reduce cardiovascular events, but as well as the reduction of the volume of the atheroma volume is going to be a reduction. It will reduce the cardiovascular events. In another word, that we have atherosclerotic process. This atherosclerotic process caused by LDL, and this LDL we have to reduce it. Once we reduce it, we confirm that there is cardiovascular benefit in terms of mortality and morbidity. Subsequently, we found as well that there is atheroma reduction by different studies, as you can see, started from the reversals ongoing for primary and secondary prevention, and they confirmed that there is a regression of atheroma. In another word, reduction of atheroma. So once you have a reduction of atheroma, subsequently reduce the LDL, by reducing the LDL, you are going to reduce the atherosclerotic events. In another word, that there is a treatment which can reduce the LDL and subsequently reduce cardiovascular outcomes. And that is the drug which we are using commonly. So it has been by consensus expert opinion of all scientists related to this atherosclerotic process and dyslipidemia. They found that increased atherosclerosis by increased LDL. And then that you reduce this, you are going to reduce the atherosclerosis. So this is a consensus which is published in 2020 by the opinion of the European Society of Cardiology. This is an interesting to see that what we have been born with particular LDL level. This is the blue shaded area, is the LDL at birth. Then this is the mean LDL, the blue line upstairs here is the mean LDL of 125 milligram per deciliter, which will be maintained up to the age of 60. Once you reach the age of 60, this 125, it goes up, and subsequently the myocardial infarction will start beyond 60 years. So 60 years in our regular patients with normal starting therapeutic atheroma burden from the beginning, they will start processing or developing the atherosclerotic coronary artery disease or cerebrovascular disease at the age of 60 and older. Now, this by the yellow shaded area or orange shaded area, this is the area where we need to interfere for primary prevention, because this is where you need to interfere to reduce the progression, because the longer the time your blood vessel is exposed to the LDL, the more the atherosclerotic process development, and the more the worse outcome. So we are supposed to interfere very early here, and that's why most of our drugs and they're reducing the LDL, they are authorized to start at the age of 18 years, as you can see in here. At the age of 18 years, when the primordial prevention is required. Primordial prevention means from the beginning you start preventing, this is the time you start introducing your drug to reduce the cardiovascular event secondary to the LDL. So if you reduce this orange shaded area, you are going to reduce the atherosclerotic burden. And here, this is where the threshold of development of atherosclerosis or coronary artery disease, this solid red line. And then you can see that in homozygous familial hypercholesterolemia, the exposure up to 12 years, you are going to have the first myocardial infarction. Heterozygous, it will be at the age of 35, you will have the myocardial infarction. Then in a normal person, the age of 60, the atherosclerotic process and possible myocardial infarction will start. That's why we are emphasizing that the younger person, younger than 60, developing premature atherosclerosis, it means that there is an issue ongoing for the LDL cholesterol. So this is indicating that the longer the duration of exposure of the vasculatures to the LDL, it's going to worsen the atheroma and then subsequently will develop myocardial event. Another area, just to show you that this is the shaded area. The shaded area, this is the atheroma burden in general for one person who has LDL of 125 milligram per deciliter. So the atherosclerotic process will start at the age of 40. Then the more the continue the same value of LDL 125, then by age of 60, you will have a higher cardiovascular events reach up to myocardial infarction of 4%. You might, by age of 80, you are entitled of 16% risk of development of myocardial infarction. So here you need to interfere at this area or before to reduce this 125 to less than this. So the cumulative effect of LDL cholesterol, which is related to the age, so they multiply by 125 milligram per deciliter multiplied by age, they will get the percentage of 1% to start at the age of 40. So having this increase the burden, you are going to have the increase the risk of myocardial infarction. And as I have said, in 125 milligram LDL by 16% at the age of 80. So if you have a reduction of LDL significantly, your age might come to 40 or 60 if you are old at the age of 80. So the volume of the burden of atherosclerotic burden will reduce the age. By reducing the atherosclerotic burden, by reducing the LDL, you are going to reduce the mortality by cutting a significant years of mortality. Here, that very interesting, it showed you that if you have LDL cholesterol 200 milligram, the myocardial infarction will start at the age of 20. If you have it at 125, as I have said before, it will be at the age of 40, you will have the first MI. At age of 60, if you have the LDL of 80, the first MI will be at the age of 60. So if your LDL is 80, your LDL is 80, the first myocardial infarction will occur at 60. You are gaining almost 40 years of years for your age without myocardial infarction. So that's emphasizing the importance of exposure of the atherosclerotic vessel or the blood vessel to atherosclerotic plaque. And that's why we need to start early, trying to prevent the development of atherosclerosis and maintaining it to be low in order to avoid atherosclerotic cardiovascular events. Here, similarly, that you have, interestingly, that you have a 40 years old man who had the myocardial infarction, another 40 years who had no myocardial infarction, despite their level of LDL cholesterol is the same. So where is the problem? The problem is that there is something called more vulnerable LDL cholesterol in a person who is more vulnerable to attract or to add the LDL cholesterol in the intimal of the blood vessels. They are called more vulnerable, like other additional risk factor is higher. And those who's less vulnerable, then the person with 125 milligram, but he is more vulnerable, will develop at the age of 20, he might develop myocardial infarction. But less vulnerable, that he will develop myocardial infarction at 60. Why? Because there is additional risk factor, additional residual issues, which we are going to talk about it later on. Here you can reduce the LDL cholesterol, and subsequently you are reduce the first myocardial infarction, but there is still residual, and that residual has to be reduced once you come in the LDL-C cholesterol less than 80 milligram. So if you reduce it to less than 80 milligram, you will come below the threshold. This is the threshold of atheroma burden above which you will have myocardial infarction. And this is why at this level you will have at the age of 50 you might start having myocardial infarction, but you might reduce it by reduction of the LDL to 50%. It might reduce to the age at first myocardial infarction at 50. But if you reduce it further by the additional reduction of lowering of LDL to reach the level of 80, you are going to have the first myocardial infarction more than 70 or around 70 years of age. So from this, we can summarize that the longer duration of the elevated LDL cholesterol and the value of the LDL, the higher the value, the longer the duration, the more the atheroma, the more the burden, the more likely to develop atherosclerotic cardiovascular events. Here are interesting things coming from the mutation. They found if there is a PCSK9 mutation, you are going to have a reduction by 15% of the LDL cholesterol. That will be interpreted to reduction of coronary heart disease by 47%. So 15% lower, it will reduce by almost 50%. 28%, doubling this number, it will double here. It will be 90% likelihood of reduction of the coronary heart disease. By what method here? By the method of malfunctioning or mutation of the PCSK9. So in another word, here we are talking about not only the LDL cholesterol alone, but there is something else which is called PCSK9, which compete the LDL receptor and subsequently cause increased LDL in the circulation, and then the atheroma burden will increase. The longer the duration will go with this, the more the atheroma development, and subsequently more cardiovascular events. This is very important to remember that PCSK9 now is being discovered to be harmful for the patient, and then he might develop atherosclerosis. So our problem, unfortunately, that we are not reaching our goal by reducing the LDL cholesterol, and in the Middle East, by this study, it was only 28%. So we are far below the target. So the problem is that we are coming good with the low risk patients, but we are not good at the high risk patients. So at the high risk patients, we are leaving him without treatment, but the low risk patient, we are reaching the target. This is a really need to be revised by our physicians. Very interestingly, this man is this couple or this two person, they are getting the Nobel Prize for their physiological discovery of the LDL receptor. So remember, they are in 1970 in Texas University, they discovered the LDL receptor. And then after that, the LDL receptor was the discovery of the medication for the treatment of the dyslipidemia. It started from the statin, then the ezetimibe, then subsequently for the PCSK9 inhibitor and PCSK9 degenerator new drugs. So this, the discovery of LDL receptor was discovering the presence or discovering the LDL receptor. What is the rule? I want you to remember very well how the LDL receptor works. Now the LDL receptor by statin, we are reducing the enzymes which prevent the development or the progression of the LDL by increasing or upgrading the LDL receptor. So LDL receptor upgraded by enzymes reduction by statin will reduce the LDL, number one. Number two, that there is a PCSK9 inhibitor and PCSK9 degenerative new drugs, which can degrade the PCSK9 even before the PCSK9 develop. So look at here, we have a significant reduction of by using high intensity in statin, but the residual risk is there. This residual risk needs to be looked at by the new generation, which is the PCSK9 inhibitor and PCSK9 degeneration. And of course, by dealing with the other risk factors like hyperglycemia, hypertension, and procoagulant and inflammation. Here, the European Society of Cardiology has shifted the target from less than 70 to less than 55. Or if the patient has the LDL cholesterol at baseline 55, it should be 25, mean less by 50%, and so on. So there is a very clear shift from 2016 to 2019 by the target in the very high risk and moderate risk or low risk. Interesting here, the very high risk patient with myocardial infarction or atherosclerosis, as in the lower part. The high risk is here in patient who has a score more than 7, less than 10, which is the patient with diabetes and short duration of diabetes. And then the diabetes itself is giving you a moderate risk. So a patient with diabetes has a moderate risk, at least if he's not having other risk factors to develop high or very high risk. So in general, no diabetic patient with low risk. They are high risk. And that's why I'm pointing to this, because hyperglycemia is one of the residual, which we are really not controlled to reach the target of our blood cholesterol. This is the drug which can reduce the lipid, the LDL cholesterol, and of course, the combination of PCSK9 inhibitor, ezetimibe, and high-intensity statin going to reduce the LDL by 85%. Now, a new drug has been added to this list, which is the degeneration, the drug which degenerate or lysosome the PCSK9 itself, and subsequently it will reduce the LDL. Here, I will touch only quickly that the guideline has recommended to start very early LDL reduction by all means, including lifestyle modification and therapy drug. And then they consider the new drug as class 2A indication to upgrade the treatment to lower the LDL cholesterol. Here, the issue of the LDL receptor. I told you that the LDL receptor discovered by those two guys who get the Nobel Prize in 1985. They discovered it in 1970. Then the advantage of that has come up. Now, this is the LDL receptor. What is the LDL receptor is? This is the LDL receptor at the surface of the liver, in the circulation side. So what happened in the hepatocyte, the LDL receptor here is like the guard. The guard, once it's open, it will open to enter the prisoners. If you consider LDL is a criminal, the PCSK9 is criminal. So the LDL receptor is a guard, which will allow this to come in. So what happened that if you have PCSK9, then the PCSK9 will come to the LDL receptor. There is no place for the LDL to come to the receptor. So there is a competition of the PCSK9 and the LDL to the LDL receptor. So if the PCSK9 came, the LDL receptor will stay in the circulation and it will go to the blood vessel. But if you take it in, then you are going to reduce the LDL from the plasma, from the circulation. So the LDL receptor is very important, and the LDL receptor is upgraded by the PCSK9 inhibitors and will be upgraded by degradation of the PCSK9. And all the study here, started from Fourier and the other study of acute coronary syndrome by the new drugs which reduce the PCSK9, all has been proven to reduce mortality and further reduction of the LDL cholesterol. And subsequently, a new drug, which is this time is dealing with the LDL receptor itself, the LDL, not LDL receptor, the PCSK9 itself, by degrading the PCSK9. In another word, that this PCSK9 will be less, then the LDL receptor will be free for the LDL to come in, and of course, to clear up the circulation from the LDL and subsequently reduce atherosclerosis, reduce atheroma, and ultimately you are going to reduce the cardiovascular event. I will not go through this all, but I am going to tell you that the longer you are going with LDL, the more likely that the atherosclerosis will develop. We have to interfere as early as possible, and we have to reach the goal as early as possible. You should not be worried about the side effect, that there is no side effect for most of the drug we are using. And then I will just here, because of time limit, I will conclude that atherosclerosis is the cause of death in Saudi Arabia and international. LDL is the main etiology of atherosclerosis. The lowest is the best for LDL, particularly in high and very high risk patients. The duration, the reduction of LDL will be interpreted by reduced cardiovascular event requiring PCI or surgery, or subsequently preventing it better than intervention. And this is a cost-effective, regardless how expensive is the drug. Long-term exposure of LDL produces an early cardiovascular reduction or early cardiovascular event, and the reduction of the burden going to reduce cardiovascular event. Thank you very much for your listening.
Thank you very much, Professor Mustafa. This is a very pleasant, enlightening lecture about the role of LDL and the targets of treatment. Looking forward for the discussion. But for now, we'll move on to the second talk. It's my pleasure to introduce Dr. Fakhr Al-Ayoubi. Again, well known to all of you. She's a clinical cardiology clinical pharmacist at King Saud University Medical City. She's also the president of the Saudi Cardio Clinical Pharmacy Working Group at the Saudi Heart Association. And she's behind most of all these activities. So we thank her a lot for that. She will be talking about the impact of patients' adherence to controlling LDL cholesterol and outcomes.
Thank you very much, Dr. Walid, for your nice introduction. Thank you very much, Dr. Mustafa, for the great information that you started your presentation with. And as you can see now, we all agree that controlling the lipid is very important. And the point here is that how can we do that and how good are we in that? This is why actually my part is going to talk about the impact of adherence. And this is the most important thing in clinical practice. First of all, we need to diagnose the problem itself. Then, of course, we need to work up how we can control it. In the end, of course, we need to see the outcome, because in the end, if I'm not treating properly, it's the same thing as if I'm not doing anything. That's why we started talking about the anti-lipid group, which started like 3 years back, where Prof. Arafa was there with us to start in the collaboration with different centers in Saudi Arabia, and to elaborate and focus about our practice as an anti-lipid practitioners in Saudi Arabia. As we know that he has a screening publication talking about the levels of hyperlipidemia problem in Saudi Arabia and in the Gulf country. We'll talk about it in details for sure. So for no further actually introduction, I would like to talk about how bad is the hyperlipidemia to the cardiovascular disease. As we saw, 80% of the cardiovascular disease is because of hyperlipidemia. And the other thing, it's more common in the middle income countries, which means it is a very important alarming information for us in the Middle East to take care of. As Dr. Mustafa said, that almost 50% of our mortality is across the age, different ages, is because of hyperlipidemia. The global the MENA number one cause of death is because of ischemic heart disease, which hyperlipidemia plays a very important role in. 22% of death in Saudi Arabia, it's because of the ischemic heart disease and cardiovascular problems. Multifactorials are there because of the coronary heart disease risks, that some of them are non-modifiable, but some of them are modifiable, and dyslipidemia is part of it. Again, the global prevalence of cardiovascular disease risk factors are high cholesterol. The relation of serum cholesterol with ischemic heart disease have been proven by evidence that it's the major cause of ischemic heart disease and, of course, death. In 1984, as Dr. Mustafa told us, these two guys who discovered the receptor of the LDL, the Times went up to say, guys, there's a good cholesterol and there's a bad cholesterol. This is where they started talking about cholesterol and the LDL levels. At that time, of course, the company which is supposed to be investigating to a molecule, which is the statin molecule, were actually trying to discover the antibiotic at that time, which ended up being the statin, the first statin produced to the market. And you can see, according to the evolution of the guidelines all over the years now, is that more condensed, more intensive treatment is recommended. The more intense you go, the better outcome you'll get. The evolution of dyslipidemia management, you can see they started with niacin in 1955. They end up with PCSK9 inhibitors, and of course, more are coming. So you can see we have a varieties and a lots of options of treatment for the hyperlipidemia, but this is not our limitation. Why do I mean it's not a limitation? Because we are trying to control the LDL, and this is not easy to do. You will see that in the coming few slides why we are not able to do it. Because as we agreed now, lowering the LDL cholesterol will lower the heart disease and the stroke. Each 30 milligram deciliter control of the LDL will decrease the cardiovascular complications 30%. Now, non-adherence is a problem. What do I mean by that? There's a problem in non-adherence for the chronic disease, specifically for hyperlipidemia, 60%. They are not adhering either to the medication or the guidelines or whatever. We will see the details now in the coming few slides. So what is the point here? We need to adhere to the proper medications. The clinical outcome studies with statins proved from 1994 until the coming years now that the more people we need to control, the more LDL we need to control, the more aggressive we need to talk about, and even not only the hyperlipidemia itself is a problem, it's also controlling the complications and the morbidity and mortality of this disease with different age, with different comorbidities. The impact of patients' adherence on health outcome for chronic disease. There was a study conducted to talk about what is the outcome of adherence to the guidelines. And it was an observational 4-year longitudinal study. They told us by evidence that patient adherence was associated with the improvement in the healthy outcome or the health outcome. So whenever you're talking about chronic disease, first of all, you have to look at the adherence. The other thing is that there was a very nice way of calculating the adherence to the goals of the LDL, which is the one called the medication possession ratio. And this is the percentage of days when medications was available for the patients from the day of dispensing till the day he comes back to the clinic. So always MPR is supposed to be more than 0.8. That means we are going to the better goal. But if it's less, that means we are not going to the better goal, either by not dispensing the medication or not taking the medication, or even the medication is not available. So again, this is our, this is the pharmacy actually tools to measure the adherence of medications by giving the proper goals for the outcome of the LDL. The scope of non-adherence, sometimes it's because of the disease itself. As you could see, cancer patients have a better adherence to their medications compared to hypercholesteremia, which cannot even exceed the 70%. Even sometimes they said it's related to the drug class. For example, you can see statin, the adherence is again not more than 70, while anti-cancer is almost reaching to the 90%. So also the class of the drug could be a problem. According to a study, they demonstrated that what is the current gap between reaching the proper LDL goal, comparing it with the guidelines. And they said it could be the lack of the healthcare practitioner familiarity to the guidelines, which is a very strong point in hyperlipidemia. It could be the cost of the medication. Some of them are expensive and they cannot afford it. Also patients related. Sometimes patient doesn't want to take high intensity medications or because of the side effects or because of compliant issue. The other concern is about the statin related adverse drug reactions. And I do believe that it's important because most of my patients will really tell me what is the side effects of statin. And we have to be frank with them. Hemorrhagic stroke is a problem, incidence of diabetes, and lots of, we heard about this in lots of talks before, and other side effects, which could be very important to emphasize and talk to your patients about. So that could be also another limit for not reaching more than 50% of the patients to the required statin dose in order to be able to reach the proper LDL level. Again, the MPR, the more MPR we get with the patients, the better mortality rate we get. So we want to decrease the mortality in these patients. Some drugs, as I told you, it's not affordable. It's a costly medication. Sometimes it's available, but the patient doesn't want to take it because of injectable route of administration. You can see now some of the medications, which is the new medications, it's an injectable medication, and patient doesn't want to be injected. In our center, we try to do a screening actually to see where do we stand in the international guidelines. And imagine 80% of our MPR proved that our practice was not to the proper statin or not to the proper dose of statin, which is a huge amount of lack of information. We did some intervention to improve the adherence. First of all, we educated, of course, our staff. We worked on some barriers of the adherence, like some of the practitioners didn't know what to do. Sometimes all medication is not available. We made it available. Sometimes we talk to the patients and tell them that how to take it, what's the proper way to do it. Lots of methods were done to overcome the barriers of adherence. Another thing, we use the technology because according to the technology, we were able to improve the patient's adherence to the medication. Now, this is talking about medication, electronic reminder. We can use also some mobile application like what we did in our clinic. It's a free application. It's a MediCoach application. You just download it for the patients in Arabic. You put the name of the medication, and then you track the medication history. You get the reports from the medications, from the patient's mobile and the next visit, and you can detect which is the bad compliance, what time is he bad in compliance, what time he's better, so you can improve it. And on the other side, of course, we want to improve the achievement of the goal of the LDL, which is very bad. Even Europe, you can see that even Finland did not even reach up to 70% of the goal that they are looking for. Most of the statins alone would not achieve the goals, even if you are giving it with a full dose, even if you are increasing it to the double, you're still not reaching more than 6% of the target LDL that the patient was on. If you combine it with statins, for example, and ezetimibe, which is one of the combinations and available in the market, only 50% within the levels that the patients would reach with. So that means I have to consider another way and another form of improving the LDL target, which sometimes even made us work very hard on. First of all, let us define the proper statin intensity. The global risk tools, you all have to download it in your mobiles, please. I will let you see now the application. Try to put the score in your mobile and try to identify your patients are from which group of the 4 groups that they have to be on statin. And then after that, you shift the target again. The treatment has to be a target approach, not a level approach. Now, the intensity of the statin, it's there here. You see atorvastatin, for example, 40 to 80 is the high intensity, and there's the moderate intensity and the lower intensity. Again, you have to differentiate between the different intensities. The 10-year risk factor has to be calculated. Your patients will have, of course, information that will be built in the risk assessment equation, which is, as I told you, it's an application. It will tell you which type of your patient is and in which group he is in. Group 1, for example, they are a chronic heart disease with stroke, peripheral artery disease, and they come with atherosclerotic origin. So it means that these groups, group 1 or group 2, the one that has a high LDL, or another ones who have diabetes on or without diabetes, these 4 groups has to be on moderate to high intensity statin, depends on the tolerability of the patients. It will decrease the incidence of fatal and non-fatal stroke up to 16%. Again, you have to know if your patient is diabetic or not to reach the level. According to the guideline, they all agreed on using moderate to high intensity statins. The difference in some guidelines is that, are we going to give it alone or in combination with other like ezetimibe or other anti-lipid medications? The other thing is if you have a type 2 diabetic or type 1 diabetic and they are 40 years to 75 years old, they have estimated risk factor of 10. That means they have to be on high intensity statin. And if they are, this is if they are more than 7.5. If they are less than 7.5, it's a moderate intensity statin. According to the guideline, you have to reach to the 50% reduction of the LDL of these patients. You have to also have a target, as Dr. Mustafa told us, it's not only the percentage, it's also the target LDL that we are looking for. And the end, which is group 4, you have to work very hard on differentiating which type of patients you are going to start the statin with. Now, there's other groups of patients who should be considering statin therapy. This should be individualized. And as you can see, the screen is there. It's available online. You can see, according to the 10-year risk factors scores, which column you will go to and individualize the initiation of statin for those patients. This Epidemia International study showed that 2/3 of the patients on this medication, on this study, were having an elevated LDL. Imagine, 2/3 were not within the LDL goal. Again, even in Saudi Arabia and Lebanon, it's proven that the adherence to the guidelines were very poor. And why is that? Why do we have a suboptimal lipid control in clinical practice? I try to summarize this in the coming few slides, and I'm here actually to share these thoughts with you because we are really trying to come over this problem as much as we can. underdiagnosis is very important because some of the practitioners doesn't know the risk calculation for their patient. So please, if you need any help, we can be there for you. The other thing is the undertreatment, and this is very common. I found that lots of our practitioners, they don't want to write statin. If they write it, they want to go with a small dose. Please be careful because you are harming your patient. The inadequate doses sometimes, as I told you, or sometimes you are putting a statin alone where the patient needs to have a dual. Like as I told you, if a statin is not giving a proper effect, even doubling the dose, only 60% would be the LDL reduction. So you might also consider combination of anti-lipid medications. Sometimes the lack of adherence is because of the patient. They have side effects, there's an interaction, they are taking the medication, but it's interacting with other medications. So it could be the reason. And of course, the most important barrier, and I do really want to take the chance of having Dr. Walid Al-Habib, the president of the Saudi Heart Association, with us to work on a national guideline where we really want to nationalize the practice of hyperlipidemia all over the kingdom in order to make our life easy. Because according to the international studies, almost 80% of the familial hyperlipidemia are not reaching the goal. And you can see even the high and very high cardiovascular risk population are not reaching the goal. Statin intolerance is a problem, and we have to tackle it in a proper way. The decision pathway has been already discussed by Dr. Mustafa. It made our life a little bit easy. It made it at least systematic. So I will consider non-statin therapy for those patients. And if there's a non-statin therapy, who should I start with and how should I do it? And this is actually a nice element that will help you a lot in considering the non-statin therapy. If the patient is not tolerating the statin, also what to do, how to monitor your patient's adherence. Your patient's adherence not just to medications, to lifestyle modifications, even to clinic appointments. The lifestyle itself has to be changed with these patients. The high risk also subgroups has to be in a very high focus, like what Dr. Mustafa showed today, that we are just concerned about the less risk patients, while the high risk subgroups, we are not looking at them. Of course, the 4 groups of statin patients. All the guidelines, as been mentioned, has been considering, of course, starting statin, going to the proper intensity and the proper combination, and what is the goal of LDL that we should reach in these patients. It's so clear in the guidelines, but we need to work it up in order to make life easy for the people who's going to apply it. How low should we go? It started by less than 1.8, but now even they are telling us less than 0.78. How bad is it? How good is it? We still have to work hard on getting the proper target. Of course, some of the limitations will tell us that decreasing so much of the lipid profile might affect the patient the patient outcome, and sometimes they will talk about diabetes or dementia. This has to be, of course, tackled properly, and we can have another webinar telling you what's the bad and the good thing about the proper control of the LDL and what is the proper target according to the patient. This is, as I told you, is the estimated risk calculator. Please download it in your mobile, make it available in the clinic. It will help you a lot because I used to use it in the clinic. My colleagues also, it helped us a lot in the screening process where we try to do in our university hospital. We try to consider some solutions for ourselves. The screening program was to start where's the problem. As I told you, 80% were not using the proper statin or the proper dosing. After that, we had to also unify the laboratory investigations, make sure that all the investigations are done with the same kids or at least the same patch number. And local scoring system is important. We had been, of course, training our staff what to use, establishing and applying the national guideline, which we had to adopt from other international guidelines, but not yet, we have our own. And of course, auditing every other time. We had a multidisciplinary educational program that will improve the adherence in the university. It was to evaluate the prescription pattern together with the dosing of the main lipid lowering agent in our patients, and to see the adherence of our healthcare practitioners to the guidelines. The study was done on the cardiology, endocrine, and family medicine. in order to make sure that our practitioners were all in the same level. We did a course of education first before we started, and then we evaluated their outcome in the 0 time, then 3 months, then after 9 months. At the same time, as we said, adherence is important. So we had to do a Moresky scoring for the patients. And to be honest with you, implementing a disciplinary educational program has a very good impact on the adherence and a very good impact on the adherence of the patient to their medication. And with the multidisciplinary team management, we had the 3 golden heroes, physician, clinical pharmacist, and nurse, to be there with the patient. We also were focusing on the guidelines and how to improve the patient care. Including a pharmacist did really help a lot in making sure that we are within the guidelines. The hyperlipidemia also, again, as I told you, was a team that were conducting all the updated guidelines, and of course, working with a team with the other healthcare practitioners to make sure that our translation to the guideline is proper, and of course, in a checklist that nobody will forget. We were integrating our efforts with all the healthcare practitioners that we had to deal with, because, you know, hyperlipidemia, it's everywhere, and you can get the patients from all sectors in the hospital. So we had to make sure that our LDL target was good. So as you could see, the first 3 months, well, again, you can see that family medicine were doing the best, but after 9 months, again, the cardiology and the endocrine were almost giving a better outcome. So I believe because of maybe could be the education part, it could be because of the rate turnover. I'm not sure what's the reason, but we still have to, of course, focus on the reason of these changes. The Moresky score, it was above 2 when we started. Not more than 40% of the patients were taking the proper medication after we went all through the right prescription, the right dose. But after 9 months, we were able to decrease it, and the patient's compliance was almost up to 90%. The quality of life of the health of the hyperlipidemia is very important, because we also don't want them to go into complications and to develop an MI. We're trying our best to work with the healthcare providers as a pharmacist to manage our patients, to be in the clinics. There's a clinic, if not, to be with the team, of course, to try our best to apply the guidelines and to control the adverse drug reactions and what to do with it, to avoid the interaction, to counsel the patients, to make tools easy for the patients to remember their medication, simplify the regimen as much as we can. Of course, cost effective is very important, because as you could see, some of the medications are expensive, but on the long run, they are more cost effective than the others, and always be updated with the proper information. Dyslipidemia is preventable. Treatment, and according to the evidence-based medicine, is very important. Healthcare practitioners are very important, crucial role in actually adhering to the treatment plan and improving the patient's quality of life. Thank you very much, and ready for your questions.
Thank you very much, Dr. Fakhar, for a marvelous talk and outline on the important topic of adherence and how it affects actually the patient optimal therapy. So I will start with some of the questions here. MashaAllah, I'm very impressed with the attendance. Above 1,200 people are attending this very interesting meeting. So now, one of the questions here is a common question that we get from our patients. I might direct it to Dr. Mustafa. If you're, many think that if you reach your target, then you can probably stop your medications, thinking that it will remain like that. So the question, I think, is from 2 parts. Should the patient continue on taking their statins or anti-lipid medications even if they reach the target? And the other part would be, is there a risk for continuing and going as low as possible when we use the medications?
Well, thank you very much, Dr. Walid. As you have said, that there is 2 parts in this. First of all, the target. I think you need to know the target. The target is not necessarily below 55 milligram per deciliter only. So if the baseline LDL is 60, your target should be 30 milligram per deciliter. In other words, 50%. So it is less than 55 or less than 50% from the baseline. So in another word, that whatever your target, if you reach it, then the second question, should you maintain the same medication? The answer is yes. Because first of all, the drug is lifelong. Secondly, that if the drug is being stopped, there is a rebound atherosclerotic process and an increase of the LDL and poor consequences. Fourthly, that there is no side effect from the drug. And the more you maintain LDL in the lower side, the more likely you will gain an outcome. As we have said, that the volume burden of the atheroma burden is number of the LDL milligram per deciliter multiplied by the time, age. So the age playing a role with the LDL cholesterol value. So this combination is going to increase with age, and subsequently you will be aging. Means that today you are 40, tomorrow 41, and so on. So we recommend that to continue the same medication with the same intensity, regardless how low you can reach, provided that there is no significant side effect or from the side of the patient.
Excellent. I would also give you the second question. Should PCSK9 inhibitors be only given on top of statins, or can we use it without statins?
In fact, this is not tricky. It's like straightforward, that we know the standard of care, that we should start with the statin, but there are some of the patients who might not tolerate the statin, number one. Number two, the side effect of the statin may be so vigorous. And then some of them, they have allergy for the statin, and those can be on an alternative. The alternative usually to start with ezetimibe, for obvious reason, is the cost. And subsequently, you can go for PCSK9 alone. So PCSK9 alone can reduce the LDL by 60%. But the recommendation in general, and for the commonly used drug, this drug commonly used for the atherosclerotic cardiovascular disease, it should be on top of statin, which is a high intensity statin, plus ezetimibe, and the goal is not yet reached. You will add the PCSK9 inhibitor.
Excellent. Now, Dr. Fakhr, I think this question was answered very well by you. You probably might want to touch on it briefly. What's the role of the clinical pharmacist in the hyperlipidemia program? Although you did touch on it, but in brief.
Yeah, actually, would like just to emphasize that part of the role is the education itself, because we need to read and update ourselves. We need to also educate the people around us, which is very important. And also to educate the community pharmacy outside, the street pharmacy. As we know, during the pandemic time, most of the medications were dispensed either by a drive-through, which is the drugs are being sent to the patients at home, or from the community pharmacy. So we also need to educate this group of pharmacists to know which statin they should give the patient and what's the dose. And of course, and the most important thing is, as Dr. Mustafa said, the combination. Where to start the combination, and when there's a side effects that we can come over. For example, insomnia is a problem with some of the patients, what to do with such a side effect. So their role is to be there, also to make these drugs available. Of course, this is important. And for the cost-effective part, because they have to also advise the team if we are going to the right direction or not.
Excellent. Now, I would like to ask you a question as well. What do you think the role of the rumors all around us about about cholesterol, and that this is not true, even unfortunately from some healthcare practitioners? How much does that affect patient compliance and adherence to their medications?
Well, you know, rumor is since I think Sayyidina Adam, it was there. We cannot deny their effect on people.
It's very strong in hyperlipidemia.
And for example, you can see now Corona, for example, they're telling us that if you take qist al-hindi or mlukhia, and again, I mean, these kind of talks sometimes doesn't make sense, but people like to believe it. We have this thing inside. We want to shy away from chemicals. On the other side, we just want to say that the old way of eating and the old way we used to cook is better than the new way, which is, again, in the end, we are going to the same rumor, which is not to take the medication. Now, I do believe that we have to, that's why, as a society, as a, خاصة إحنا أهل العلم, we have to answer them in a proper scientific way, but in a simple way. يعني حكاية إنه أطلع study والله evidence based blah blah blah, it's not going to convince your public. So the more we do for the awareness, it will help. Also to advise people, please don't listen to anybody. You have to listen to people who are authorized, people who's really working very hard to update their knowledge. And again, rumors are there. You cannot stop it, but you have to evaluate what's the outcome of it.
Excellent. A question to both of you, actually, because you mentioned that some of the side effects or some of the complications that might happen with use of anti-lipids are like diabetes or dementia, and the new guidelines are telling us the lower the better. So Dr. Mustafa and Dr. Fakhr, do we have clear evidence that if we go too low, like down to zero, would not affect our health, and how low should we go?
Thank you very much. I think this is an important question for most of our practitioners, because this is an old belief that the higher the cholesterol is better, because it is part of the cell membrane of the brain and the cell membrane of other part of the body. But this has been evaluated by scientists and by investigation, and they found that the LDL is the major enemy, and it can be reduced anywhere. But whatever the low reduction, we are talking about the LDL in the circulation. We are not talking about the LDL on the cell membrane. The LDL on the cell membrane of the brain and the cell membrane of other organs, because that sometimes they said there is maybe a cancer. This is not true, because the cell membrane with the lipoprotein in the cell membrane of anywhere in the brain or in another part of the body has not been touched by the medication. The medication will deal with the circulating LDL, and it will prevent a huge number of LDL in the circulation, which will be deposited in the endothelial tissue of the vessel. So that's what will happen. So the evidence by the study that if you go as low as 50 milligram per deciliter has been proven by 4-year trial that there is no any side effect whatsoever, no diabetes, no cognitive dysfunction, no Alzheimer, nothing. It has been there for a good study, and they found that there is nothing up to 50 milligram per deciliter. Up to zero level, there nobody knows. But however, there is anecdotal report of zero level of LDL without any consequences when it was detected only zero level. So in another word, that the lowest, that is the best zero level is anecdotal case report has been there without any problem. But the 50 milligram per deciliter was significant in more than 600 of patients, which has no side effect whatsoever.
Just to add the point, Dr. Mustafa, still, I agree with you. There's no evidence to support that low. Yani, we can go, as you said, up to 50. Less than that, it's a risky area where we have to evaluate the evidence, which will not support less than 50. Another thing is the drugs itself. They have a large molecule which will not penetrate the brain or the places where we are expecting their side effects. So, as you said, it will work on the serum. But if it's not supposed to be there, so why did God create it in our serum? That's the other question. The rumors will keep on talking about it. So yeah, I agree. We can go low, but not so low till we've proven the evidence to support our practice.
Yeah, but the God has not produced the LDL in your circulation. You are the one who put it there, because you are eating a very clear junk food. You are doing a lot of inactivities. You are not doing what's supposed to be done in order to say that God has put it. The God has been putting mutation, has put a disease there, like familial hypercholesterolemia. Why the God put it? And the patient will die at the age of 10 years or 12 years, as I have shown you. This is a disease. Once the disease process occurs, you have to deal with it.
True.
Well, it's very nice to end with a question and a debate, opening for further topics and meetings, inshallah. There are lots of questions, but unfortunately the time has come upon us. I'd really like to thank our both experts and speakers on their marvelous talks and discussions. I would like to thank Novartis for sponsoring this event, the Saudi Heart Association and Kunuz Ritaj for conducting it. Looking forward to see you in further meetings, inshallah. Kull aam wa antum bi khair.